Okay, everybody, today's lesson is on chapter 31. I think it's 31. Yeah, 31. We're going to do hypertension, high blood pressure. It shouldn't take too long. It's not a super long chapter, but it's really important to understand this because everybody and their brother has hypertension. So the way that we define hypertension is sustained blood pressure greater than 140/90. So if you'll recall, normal blood pressure is about 120/80, systolic over diastolic. And when somebody has hypertension, they have 140/90 for a sustained period of time. By sustained, I mean two separate readings. There's something called white coat syndrome that a lot of people have, where they'll go in for their physical exam, and they freak out when they see a doctor or a medical office, and a lot of people have that. And any time that your body is in a stress response or a nervous response, your blood pressure goes up. You want that. It's a normal fight or flight response. But when it continues to occur, then you know that you've got hypertension and not just white coat syndrome. Another way that you can sort of fix or assess for white coat syndrome is don't walk in and charge your patient and with all the blood pressure equipment and say, okay, we're going to take your vital signs. Call them down, talk to them for a while, might have to distract them. It's a good idea to have your patient, this is like in a clinic, not if they're in the hospital. So if they just come in for like a routine physical exam, they have them sit in the chair, feet flat on the floors, just kind of relax. And then you can take it in one arm. If it's high in that arm, you can try it in a different arm, do some other things, come back and take it again. And then the other thing that's important when you're doing an assessment to find out if somebody has hypertension is you do need to ask about over-the-counter medications. A lot of over-the-counter medications, especially the cold medications, will increase blood pressure. So patients who are known to have high blood pressure should be advised to not take medications with ephedrins in it, like Sudafed, Afrin, the things that cause vasoconstriction. And this makes sense because if your patient has a cold and they're all stuffy and their face is all swollen, if they take a Sudafed, it causes vasoconstriction, which is nice because then all of the congestion goes away and you feel better and you can breathe. However, if you also have hypertension and you take a cold medication that causes vasoconstriction, you can make the situation worse. So that's one thing you need to keep in mind when you are teaching and evaluating a patient who has high blood pressure. Okay, so up here on the board I have this. We're going to refer to this a lot in this lecture. This is a vessel, and like a vessel up and down this way, and this is the cross section of a vessel. This is what we're going to talk about when we're talking about high blood pressure, because when somebody has high blood pressure, this is the problem. It is it's on the arterial side. Nobody cares about the venous side. Hypertension is a problem on the arterial side. That means it's coming out of the left side. Everything's coming out of the left side of the heart. There's too much pressure in it, and there's too much pressure in it for a variety of reasons that we're going to talk about. So I did want to make sure that you're all familiar with certain terminologies, and I mentioned most of them when I gave you guys chapter 25 when we were talking about hemodynamics, but I just wanted to make sure that we're all on the same page. The ejection fraction is part of the cardiac output. So I should have drawn this up here earlier. So here's your cardiac output, your heart. This is your left ventricle right here. And during systole, when that left ventricle is contracting like this, it is ejecting all of this blood that's in here. Remember, that's called your preload. That's the amount of volume that's in the left ventricle at the end of diastole. So then during systole, when that ventricle is contracting, all of this blood is coming up into the aorta, and then all of the rest of the arterial system And the ejection fraction is how much blood is ejected from that left ventricle with every beat. It's a percentage. It's a percentage of how much is blood is being ejected. That's your ejection fraction. Your cardiac output is the amount of volume that is being ejected. And if you remember, your cardiac output should be between 4 and 8 liters. 8 liters being for a big, huge guy, 4 liters for a little tiny person. And then your stroke volume is the amount of blood that's being ejected with every beat. Cardiac output is the amount of blood for every minute. Stroke volume is per beat, and the ejection fraction is the percentage of how much blood is being ejected. And there will be a little bit of residual at when the ventricles contract, but you want your ejection fraction to be up at least over 80 and preferably up over 90% of that blood should be ejected. When your ejection fraction is starting to get low, like in the 30s and 40s, that means that the ventricle is trying to contract, but it's just not contracting enough. And so you're dropping your ejection fraction. And we'll talk about more about that when we talk about congestive heart failure, but I need you to be familiar with those words when we're talking about ejection fraction. Also, systole versus diastole. This should be review for everybody, but if you'll recall, systole is when that left ventricle and the right ventricle, when the ventricles are contracting, that's your systole, and that's going to be the high number. So when you're listening to somebody's blood pressure, the top number that you hear, that is your systolic pressure. That's the amount of blood that is being ejected when that left ventricle is really working hard. And then this number over here is the amount of pressure when that left ventricle and the right ventricle, but hypertension is just left side. You also can have pulmonary hypertension, and that's on the right side. But every time I'm talking about this, we're pretty much going to talk about the left side, the hypertension. So the diastolic number is when that left ventricle is filling with blood. And this really becomes kind of a more important number because if your ventricle is relaxed and it's still under heavy pressure, it never really gets a break. And what is happening, what this is a measure of, is this, the lining of these arteries and how much pressure is being exerted against them this way. So you need some pressure in there, but not too much. The easiest way to think about this is like a garden hose. So if you have a brand new garden hose and you attach it to the faucet outside, when it's brand new and it's nice and warm and summery outside, that hose is really malleable. You can move it around. It's easy to maneuver in and out. This would be equivalent to young arteries, arteries like 18 to 65. As a person ages, similar to as that garden hose gets older, it's been outside, it's been exposed to the elements, that hose now starts getting kind of hard and it can get cracks in it. It can, it's not as easy to move, and that's also what happens in the arterial system as people age. When the hose is more malleable and flexible, it can accommodate different pressures a lot easier. And then I want you to think of the spigot, the faucet that you turn on, as the cardiac output. So if you turn that spigot on full blast, you are going to get a lot more pressure inside here than if you just trickle that faucet. If you just turn that faucet on a little bit, you're going to have less fluid in here and the pressure is going to be less. Two reasons this is important. One is the malleability and the flexibility of the arteries contribute to blood pressure, and how much volume is in the system contribute to blood pressure. There's a lot of different things that can cause a person's blood pressure to be too high or too low that we'll talk about. But if you sort of think of it in those garden hose terms, that'll sort of give you a metaphorical perspective of how the blood pressure works. The other things that I want to talk about are but maybe we'll talk about that when we talk about coronary artery disease. I just want to make sure that you're aware of, but I think it's in your book actually, about some of the different tests that you can do to evaluate somebody's arterial system, because the problem with people who have high blood pressure, as you'll recall, this is our aorta, and then it comes back around and feeds the heart. These are your coronary arteries here. It also goes up into the carotid arteries, going up into your brain, as well as your retinal arteries in your eyes and your kidney arteries. Those places become very sensitive to having high blood pressure. So, a couple things. If your young patients, especially in your male patients, if they come in and they are complaining of premature ejaculation, check their blood pressure, because as you know, when a man gets an erection, their penis fills with blood. Well, if they're having premature ejaculation, it could be that they have too much pressure going there, causing the ejaculation to occur too quickly. Check their blood pressure, because they might have underlying blood pressure problems that they don't know about. A ton of people have no idea that they have high blood pressure. This is especially prevalent in the young population because they don't typically go in and have physical exams done. They are doing that a little bit more often now, especially in the athletes. They have to get physical exams done more often. So that population, it shows up that they have blood pressure problems sooner than people that might not be an athlete. They walk around, they have no idea they have hypertension. Another sign and symptom of hypertension that you need to check for in your patient is sustained headaches, which makes sense, because if you have extra pressure going up through these carotid arteries up into the head, your brain is in the skull and it just cannot accommodate that much pressure, and so the patient will get a headache. Flushed skin, because the arteries in the face will start swelling up. That can be an indication that a patient has high blood pressure. After having high blood pressure for a long time, then you can start seeing some kidney problems, because the renal arteries, they start getting inflexible and hard, and so they don't work as well. So then you start getting protein in the urine, microalbuminuria. I can't ever say that word very well. I'm lecturing. Get down. So then, that's why it's so important in a patient who has hypertension to make sure that you try to get that hypertension under control with medications, because long-term effects of sustained pressure in the arterial system will lead to complications down the road. Kidney problems is one of them. And then stroke is another one, because what can happen in sustained hypertension and heart attack can happen as well. And this is why. So if you have sustained blood pressure that is considered hypertensive, what happens is it's called, like in the brain, it's called a hemorrhagic stroke. And what happens is, after a prolonged period of time of constant pressure on the inside lining of these arteries, pretty soon these walls just can't handle it anymore. The pressure just gets way too high, and you might have seen this if you've ever had a garden hose, where you turn it on and all of a sudden there's a little outpouching that's just starting to get super thin, and you'll turn that hose on and all of a sudden it just ruptures like that. That can happen in high blood pressure. That's called a hemorrhagic, meaning bleeding, stroke. It can happen up in the brain. It can happen in any of the arterial systems. It's kind of common, people who have abdominal or aortic aneurysms. You can have an aneurysm in the brain. An aneurysm, you can be, oh, did I do this wrong? Oh, dear. I don't think this is a thing. Whoopsie. Oops. I'll fix that later. Okay, so I guess I should quit using it, actually. Let me switch this up. So an aneurysm, and we'll talk about this next semester when we do neuro. A lot of people are actually born with an aneurysm, but sometimes over years, and especially people who've had high blood pressure for a long time, they can develop aneurysms like this. And it's like a little bleb. I'm sure you've seen these in a garden hose where it just kind of gets a little blebby and weak. And then with extended pressure, that can rupture. Another thing that can happen is something that's called an arterial dissection. And if you'll remember, you've got several layers to the lining of your walls, and a dissection is where just part of the inside lining of the artery breaks open. And so what happens then is the blood comes out from here and starts filling in the space inside the arteries. That's called an arterial dissection. It's also a very scary situation, because even though the heart is pumping and it's going into the arterial system, it's not going out here, but it is going in here. So it's still not getting down to the end target organ that it's supposed to be getting to. Okay, so when you find out that your patient actually has hypertension, then you have to fix it. The biggest problem is hypertension that is not well controlled, because it leads to stroke. It can lead to heart attack. The other problem is with hypertension, it's very common in people that are obese. It's very common in smokers. Smoking will increase blood pressure. The other thing that goes hand in hand with hypertension is hyperlipidemia, meaning fat globules, too many fat globules floating around in the bloodstream, and also cholesterol. Cholesterol, you need cholesterol. Cholesterol is useful for cell membranes, to keep them malleable. If you didn't have cholesterol, you'd be really stiff and rigid. But you need your cholesterol to be less than 200. And this is a huge problem in the United States. Everybody has high cholesterol. And there's two kinds of cholesterol. There's HDL, which is high density lipoproteins, and LDL is low density lipoproteins. You need both of them, but very specific amounts. You want your total cholesterol to be less than 200. And then the breakdown of this, you want your LDL and your HDL, and this ratio is kind of important. And this is in chapter, let me just make sure I'm telling you this right, because I don't want to go off on a tangent like I usually do. Oh shoot, it is in chapter 25. I'm going to tell you about it anyways, just because it's really important with high blood pressure. So if you have higher LDLs, and your LDLs, you want this one less than about 160. So of your total 200, you want your LDLs less than 160, and you want your HDLs less than 40, like that. Your LDLs are the ones that kind of deposit in here, like that. Your high densities are the ones that pull the cholesterol out, like that. So you need some, but if you have too much, and people in the United States have super high cholesterols, then what happens is it'll start depositing on the inside of the arteries. It just kind of lays down all this extra cholesterol in there. Well, what happens is the body doesn't like that. They don't like extra cholesterol. So then the inflammatory process starts in here. The body recognizes this as something it doesn't like, so it initiates the inflammatory response. And then what happens is some of this cholesterol can break off. And now we're in an artery, so let's put our little cholesterol over here. Cholesterol loves to deposit in the coronary arteries. It loves to deposit up in the tops of, like up in the aortic arches up in here. The problem is now, if a piece of cholesterol breaks off, and remember we're on the arterial side, so it's going towards the target organs. If that piece of cholesterol breaks off and if it goes down into the coronary arteries like this, now it's going to block any blood flow from coming to that area, and that's called an ischemic event compared to a hemorrhagic event. If the cholesterol swims upstream like this, then it gets lodged. This is my brain. I'm going to draw my carotid arteries down here. Okay, so here's my piece of cholesterol. You can get cholesterol in your carotid arteries too. Then it swims upstream and these arteries get smaller and smaller, and then it'll lodge up here and no more blood flow can get beyond that, and then that becomes an ischemic stroke, or in this case it's a myocardial infarction. So when your patient has hypertension, you can either have a hemorrhagic event because the pressure gets so high that it ruptures an artery, or you can have an ischemic event related to high cholesterol, hyperlipidemia inside the arterial system. So a couple different things can occur when your patient has hypertension. So now that we've figured out that your patient has high blood pressure, what do you do about it? Okay, well, step one, there are a bunch of reasons a person has high blood pressure. If you can fix it, fix it. Always, always, always fix the problem, or at least try to. The problem with hypertension in the United States is Americans tend to not exercise and they tend to not eat healthy. Two big contributors to hypertension. If you have a motivated patient, and absolutely give this a shot, try to teach them healthy diets. And by healthy diets and somebody who has hypertension, they should be on a low fat. That'll fix this problem, the hyperlipidemia, high cholesterol. Low sodium. If you'll remember, sodium follows water. And another thing that you can do to reduce somebody's blood pressure is reduce volume. So if you put them on a low salt diet, they're less likely to retain water, and that's one way you can help reduce their blood pressure. So diet. Another one is exercise. If you can get the heart to be very efficient, so that when it is pumping, it's very strong and working well. The other thing that exercise does is it starts to eliminate hyperlipidemia and cholesterol. We know the studies have shown that if you exercise and work out 30 minutes most days of the week is enough to keep the cardiovascular system working well, reduce lipids, reduce cholesterol, improve efficiency of the heart, and you are more likely to be able to control blood pressure. So diet and exercise. Absolutely, if they're smoking, prescribe or suggest a smoking cessation program, the Nicoderm patch, something to try to get them to stop smoking, because that contributes to vasoconstriction and increased blood pressure and a variety of other things. There's other problems, obesity, obviously. So if you have a good diet, exercise, that also is going to help reduce obesity, which will contribute to this. But there's other things that you can't fix. For example, hypertension tends to occur as people age. There's more hypertensive people that are 65 and older. Well, you can't change somebody's age, obviously. Family history contributes to it. Hypertension tends to run in families. Sometimes you'll find that you have a very thin, fit person who's hypertensive. We don't have an explanation for that. It's just hypertension of unknown etiology, meaning luck of the draw. We don't know why this person has high blood pressure. So if you can find out what the problem is, fix the problem. If you can't, if it's non-modifiable risk behaviors, then you just track it and monitor it. Okay, so the other things that I wanted to talk about, oh, yeah, I know what I wanted to talk about. We mentioned this a little bit sort of in endocrine. There is primary hypertension and secondary hypertension. Primary hypertension is kind of what we're talking about. It is the disease process. It's just a standalone disease process. But sometimes a patient will have something else that's causing the hypertension, and if you can fix that something else, then the hypertension will go away. Pain is a big contributor. People that are in pain, their blood pressure goes up. It's just a stress response. So if you can fix the pain, you'll reduce their blood pressure. If you remember from endocrine week, people that have adrenal adenomas, adrenal tumors, that can increase blood pressure. Patients who have a problem anywhere along that adrenal aldosterone renin system. So like if the kidneys are producing too much renin or something along that pathway isn't working, and I'm going to post that adrenal aldosterone renin angiotensin system again so you can understand that blood pressure mechanism. But if you have something going wrong in one of those hormonal cascades, that can lead to high blood pressure. That's secondary hypertension. And so oftentimes if you can fix what the primary problem is, you'll fix the hypertension. So there's two different kinds of hypertension. The other thing I wanted to talk about is the pharmacy for hypertension. Hang on, that's not what I wanted to do. So when somebody they're diagnosed with hypertension, usually what they do is they have to be put on medication. So there is a good diagram in your book. Let me see if I can find it. That it kind of shows. Oh, that's good. The pathophys on page. The pathophys on page 863 that tells you the pathophysiology of the blood pressure. That's a good example of what I was talking about, but that's not what I was looking for. I thought I saw a good. I do this all the time. I see stuff and then I can't find it. I guess it's not in here. Huh. Oh well. Anyways, I was just going to try to tell you. Oh, I know where I saw it. It's on the PowerPoints. So if you want to pull up the PowerPoints for this chapter, and it's the one about factors involved in the control of blood pressure. That's kind of helpful if you need, sort of more of a more information about how the blood pressure thing works. Let me turn that up because I'm just trying to see if they have a good. No, that's not what I want to talk about. Okay. What I wanted to get to are once you figure out that your patient has blood pressure and they've done everything that they can do to get it under control, and it's not working. You don't sit for very long with somebody who has high blood pressure and not treat it, because the risk of heart attack and stroke are so high, and unsustained blood pressure to the arteries for a long enough period of time will start leading to damage in those arteries, especially the kidneys and the eyes. So you need to start the patient on medication, and hopefully you're going over this in pharmacy right now. But there's about 6 kinds of medications that they start putting a patient on, and there's a ton of meds. A lot of them are fairly cheap now because they've been around for a long time, and you can get the generics, and so the patient doesn't have to have the trade name. But you can put a patient on a diuretic, and this is an easy one. Usually they put them on the thiazide diuretics because it's not like a loop diuretic, where the loop diuretics tend to waste potassium. The thiazide diuretics don't work in the loops of Henle, and so you don't tend to have the potassium wasting that you do with somebody who's on potassium wasting, like Lasix. So anyways, if a patient is diagnosed with blood pressure, hypertension, the easiest thing to do is put them on a thiazide diuretic, and it makes sense because what it does then, use the right one, is it reduces the amount of fluid inside the vessel. That's easy. You just pee more, And so then what it does, it just allows for more space in here, which makes sense. So you just, you know, pull off a little bit of extra fluid, and now you have more space and you've reduced your blood pressure. That's one of the easiest ones to do, is just put somebody on a thiazide diuretic. The other things they can do are beta blockers. Beta blockers slow down the workload of the heart. They slow down the contractility. So it's just kind of like, if you put somebody on a beta blocker, it's just like turning the spigot on the hose just down a little bit. So instead of it running really, really hard, it's just running a little bit slower, so that you're not shoving so much fluid in here so quickly, and it's easier for these arteries to sustain that. So, and then you can put somebody on an alpha blocker. Those are, they just sort of relax some of the smooth muscles so it's not so tense in there. Some of the alpha 1 and the beta blockers, they have completely opposite reactions in the pulmonary system as they do in the cardiac system. So some of your patients who are on some of the beta or alpha adrenergic blockers can also start developing a cough. So if you put your patient on a certain blood pressure medication with the beta adrenergics, and then that patient starts to cough, they're getting an allergy to it and they need to switch over to something else. That's not that uncommon to have happen. Anytime, so let me finish this. So another kind of medication you can put a patient on is a vasodilator. The vasodilators work very quickly, and they're excellent in a hypertensive crisis, meaning this blood pressure is out of control. Like we're talking 200s over 100s. A hypertensive crisis needs to be dealt with very quickly because of the very high risk of hemorrhagic stroke in the brain, because the arteries in the brain are fairly delicate, and if they're under sustained pressure for that long, the patient can have a hemorrhagic stroke. So you've got to get that blood pressure under control, and the vasodilators are really good to do that. So your vasodilator drugs just do this. All they do is they just dilate that, so you've got the same amount of volume in here, and it just goes, you know, now there's more space in there. Same like if it was over here, it would just open that up. So now you have the same amount of fluid in there. It's just relaxed those arteries and it's given more space, and now it has released some of the pressure. When you're treating patients with vasodilators and diuretics, you do need to follow their I's and O's fairly closely, because you can volume deplete them pretty quickly. So you do need to be kind of careful to monitor their fluids while they're getting treatment. Some of the nipride, nitroprusside, those are the kinds of IV medications that you would give IV in a hypertensive crisis to cause vasodilation. And the exact opposite is true if your patient comes in with hypotension, like in a severe hypotensive crisis. Then you give the drugs that cause vasoconstriction, like dopamine and dobutamine. You're going to give to cause vasoconstriction, which is going to increase the blood pressure. So that's how those vasodilators or vasoconstrictor medications work. Another kind of medication that you can put your patient on is a renin inhibitor, and you remember, or an ACE inhibitor. The ACE, the angiotensin converting enzymes that come out of the lung, or the renin that comes out of the kidneys, all of that's along that cascade that monitors and controls blood pressure. If you can stop it anywhere along the path, then you can control blood pressure, which is how the ACE inhibitors and the renin inhibitors work. And I'll explain that more when I show you that other video about the renin aldosterone system. Calcium channel blockers are another group of medications that you can put a patient on. Those work, they work again to relax the muscles, because remember calcium is used in the contractility of the muscles, so your calcium channel blockers are just going to kind of relax these muscles so that they're not working as hard, and so they're just a little bit more malleable, like our hose theory. Typically, your patients will start out on one medication. They'll come back, especially if they're not in crisis, if they're just kind of up in the 140/90 range. And then they'll try the medication for a while, come back, have their blood pressure reevaluated, and then see how it's doing. Hopefully they've also done their diet and exercise. And if the blood pressure is still high, they may have to add another medication. Many patients that you have that have high blood pressure will have more than one medication that they're using to control their blood pressure, depending on how bad it is. Okay, I think that is all I wanted to tell you about this. Let me just see if there's anything else. Yeah, I think that's it. I think that is all I wanted to tell you. Yeah. So that's hypertension in a nutshell. It's kind of I kind of flew through it, so you might have to listen to it a couple times. But if you think about it, it's simple. It's an arterial problem. You've either got too much volume, you got the hardening hard arteries, or too much pressure on the arteries, or too many things inside the arteries, or something causing the blood pressure, like an adrenal tumor or something like that. That's what hypertension is in a nutshell. And so if you can fix those things, great. If not, we've got medications to treat it, and then you just have to prevent the side effects of having hypertension for too long. So there you go, chapter 33, hypertension in a nutshell.